Good morning, I am Sanjay. What's your name?
I'm Giri Prasad.
What's your age?
I'm 21 years old.
Did you have any caffeinated drinks before the procedure?
No.
Or do you rush to the hospital?
No.
Before the procedure, you should make sure that you wash your hands. Before the procedure, make sure to sanitize your hands. Make sure the patient's hand is at the heart level and leg is uncrossed. Give your hands. We have to take the right size cuff. We have to make sure that it's not too big, not too small, so that the measurement will be accurate. I made sure that cuff is placed about 2.5 cm above the antecubital fossa. Now I am going to palpate the radial artery. I am going to inflate the cuff. So the pulse stopped at 110. So now I am going to place the stethoscope in the brachial artery and listen to the throat cuff sound. I am going to inflate the cuff plus 30 mercury to the previous value. So his systole is 110 and diastole is 80. I am going to inflate the cuff. Thank you for your cooperation.
Before starting the procedure, we have to sanitize our hands.
Test each eye separately and ask the patient you have any spits. Place the channel chart 10 to 20 feet distance from patient.
Cover your one eye and read the possible lines.
TEF, PO, TEC.
Okay. Cover your another eye.
DE, FPO, TEC.
Test the both eyes together. Tell the patient to look directly onto our eyes and place the hand 2 feet distance apart from the patient to start the wiggle finger.
And tell me when you see my fingers. Okay.
Okay.
Cover another eye. Okay. Next.
Test the eyebrows, any disruptions, lesions, and eyelids, any swellings, edema, erythema, poetic lesions. Assess the palpable features with the patient looking straight ahead and describe its normal and any abnormal. Observe the position of the eyeballs within the bony harbor. Hold a pen as a target in the midline above the eye levels, about 20 inches away. Move the target rapidly downwards in the midline. Watch for the appearance of white sclera between iris. Check the direction of growth, matching of eyelash. Ask the patient to look up as you depress both lower lids with your thumb.
Downwards. Look upwards. Downwards. Okay. Repeat the another eye. Upwards. Downwards. Okay.
With oblique lighting for the pen light, inspect for transparency, clarity, scars, ulcers of the cornea. Check the iris axis colors. Observe the pupil size, shape, symmetry, reactions of light. Observe the pupil of her sizes. Wearing observes any regulations or dim the light. Ask the patient to look into the distance, shine or bright light obliquely. Observe the direct response, same eye, and indirect responses opposite eye. Afferent pupillary defect by moving the light from one pupil to another, back and front.
Okay.
Ask the patient to look at near finger, which will lead to pupillary dilation, and simultaneously to further, which will lead the pupillary constriction. Due to simultaneously, and you will lead to observe pupillary dilation and pupil contraction. The examiner places himself approximately 1 meter in front of the patient. Ask the patient to look to each side, up and down, followed in H pattern. Ask the patient to follow a target's pen with their eyes, without moving their head. Sit or stand at the patient's right eye for examination of their right eye. Place the O in the illuminated dial. Take the otoscope in the right hand and hold it vertically in front of their own eye, with the light beam directed towards the patient, and place your right index finger at the edge of the lens dial in order to change lenses easily if necessary. Instruct the patient to look straight ahead, preferably at some distance object of.
Hello, my name is Dimani Neharaj. I'm a second year med student from University of Perpetual Health System Data, Las Piñas, Philippines. I'm here to do your ear examination, Mr. May I know you?
Yes,
Okay, what's your name?
Nishant.
Okay, Mr. Nishant, before I start the process, I would like to wash and sanitize my hands to avoid any infections and disturbances during the process. Mr. Nishant, kindly feel comfortable and make yourself free, and let me know if you feel. We'll start the physical examination with the ear pinner first. I completely find the external ear to be normal, as there are no lumps or lesions or deformities, congenital defects, and there are no surgical scars even. The surgical scars are found at the root of the hilum and tergus and behind the pinna. If I found any inflammation or pain, I would go for the Turk's test. The Turk's test in the Turk's external auditus or auditus externa. I would firmly rub the tergus and the mastoid bone. If I would found any tenderness, it would be mastoiditis. And I would like you to know about the otoscope. Otoscope is usually used for the ear examinations. And when I am inserting this, if you feel any pain, please let me know. Usually choose the specula. Specula size bigger than the ear canal, so that you will find easy to insert it and the patient won't feel any pain or a problem during the process. While placing the specula inside the canal, gently and firmly hold the pinna up and move it backwards and downward, and position the patient's head so that you can see the eardrum to the ear. I did not find any cecum discharge or any foreign body swelling or redness inside his ear canal. Instead, I found everything to be normal. The pares fasciculata and the margins of the pares tensa, and to the cone of light, I could even see the eardrum to be purplish grey, which is completely normal. It's the short process. Make sure to examine the other ear with the same process. And Mr. Nishant, do you feel any hearing loss?
No.
Okay. Usually we go with the whisper test with the patients who feel the hearing loss, and you have to stand 2 feet behind the seated patient and whisper words. So whisper words and ask your patient to repeat the words. Completely breathe deeply and exhale, so that you would get a soft and gentle sound. Rub the patient's tergus gently in a circular motion to prevent the transfer of sound to the ear, and tell him to repeat whatever you say. Start saying with a low voice and then gradually increase the voice. Can you please repeat the letters what I say?
Okay.
A,
A,
B,
B,
C.
C.
In completely normal patients, the patient could repeat the 3 out of 6 actually. And now we'll go with the Viper's test. We'll choose the tuning forks with the frequency 512 or 256 Hz, as they are the tuning fork with your fingers, or you can even tap it on your knee, and place it on the head of the patient. Can you feel the buzzing or the vibration equally on the both ears, more or less, or directly on the midline?
Directly on the midline.
Okay. It is completely normal if the patient is finding the buzzing sound to be on the midline. And now we go to the Rennie's test. And in the Rennie's test, we buzz the tuning fork and place it on the mastoid bone, or we place it in the U shape of the canal. This is for the bony conduction and this is for the air conduction. Usually the bony conduction, can you feel it? And place the tuning fork exactly after the patient says no, so that you can encounter the patient can feel it or not. And this goes with the ear examination, and it's completely normal according to me, and I did not find any abnormalities in the patient. Thank you. I did not find any
My name is Narendra Kumar. Today I am here to check nose and mouth examination. What's your name?
My name is Ganesh.
Okay. First. Now I am going to do nose examination. First I will do observe any deformity and asymmetry. Now I will do palpate. Now I start with nose examination. First I will observe any asymmetry and deformity. After that I will palpate. Palpating the sinuses. First frontal sinus, then maxillary. Now I will observe internal structure of nose. Now I will observe the sinuses using the help of pen light. Now I am done with nose examination. I will start with mouth examination. Now I will observe the mouth, lips, lips color and teeth. Now I will palpate. Now I will observe the mouth from inside. Open your mouth. With the help of broomsticks, I will hold the tongue to check the left right of tongue and mucosa. Open your mouth and say ah.
Ah.
Say ah.
Ah.
Open your mouth, tongue out.
So we will be doing the physical examination of the oropharynx. And what's your name?
My name is Amy Singh.
So now I'm starting the physical examination of your oropharynx and neck. We will start with oropharynx first, okay? So firstly we will wash our hands prior to starting the physical examination. So now we will be starting the physical examination of oropharynx. We will firstly examine the lips. So now we will examine any kind of ulcers, abrasions or any kind of lesion or edema in the lips, any kind of swelling. Okay. Now we will examine the gums and teeth. So we will just palpate and try to examine any abnormality in the gums and the teeth. Okay. We will be examining the roof of the mouth and the tongue. So first we will examine the roof of the mouth. Please open your mouth. Then we will examine the roof of the mouth, that is the hard palate. We are looking for the color. Okay. So now we will examining the floor of the mouth. Here we are also looking for the color and any kind of ulcers or any kind of abrasions. Now we will examine your tongue. Please take your tongue out. Now we will noticing any kind of ulcers or any kind of abrasions or lesions, and we will also notice here the dorsum of the tongue. Okay, so it looks fine to me. Okay. So now we will going to examine the oral mucosa of the patient. In this we need a tongue blade and a pen light. So first of all we will just shine the light on the patient mouth, and then we will notice any kind of white color or any kind of color changes or lesions or ulcers in the oral mucosa. Okay. Now we will going to start the physical examination of the lateral aspect of the tongue. So please take your tongue out. We will use a tissue or napkin. We will just grab the tongue and we will notice the lateral aspect of the tongue. We will notice any kind of lesion or ulcers or any kind of color variation. So now we will physically examine the pharynx. So now please open your mouth. We will use the tongue blade without protruding your tongue. We will put depress your tongue with the tongue blade. Then we will examine the posterior pharynx. So you have to pronounce "a" in a loud voice. Yeah, there we can see the posterior pharynx. Now we can also examine any kind of tonsils in the tongue, and we can also examine the uvula. So this is how we can do the physical examination. So now we are doing the physical examination of the neck. In this we will firstly examine the trachea. Now we will palpate the trachea of the patient from the one side, from the midline of the trachea, in order to check any deviation between the trachea and the sternocleidomastoid muscle. From the other side, we will all do the same process by palpating the trachea. So the both comes to be symmetrical. There should be no deviation. So now we will doing the physical examination of the neck. In this we will check the patient swallowing. So you have to drink some sip of waters. You have to swallow the water. So as the patient is swallowing the water, you can see the cercoid and the thyroid cartilage and the gland is rising up and then fall back to its normal position. So now we are going to palpate and physically examine the thyroid gland from the posterior aspect. So we will ask the patient to drink some sip of water without swallowing the water. Now we will making the person neck flexing so that the sternocleidomastoid muscle get relaxed. Now we have to put our fingers both the hands on the throat, keeping in mind the index finger should be below cercoid cartilage. Now I will ask the patient to swallow the water. So now we will pressing the left fingers towards the right in order to palpate the right thyroid gland. Similarly, we will repeat this on the right side to palpate the left thyroid gland. And meanwhile, we have to notice all the symmetry. We have to notice all the symmetry and the shape size of the thyroid gland, and we can also notice the thyroid isthmus here. So we will be examining the lymph nodes here. So we will first examine the preauricular lymph node, now the postauricular lymph node, now the occipital lymph node, the tonsillar lymph node, the submandibular lymph node, then the superficial cervical lymph node, posterior cervical lymph node, then the deep cervical chain, supraclavicular lymph node.
Hi, myself Tabiswal. I am student of medical second year, and today we will be performing the lung examination. So in this you have to remove your t-shirt. Is that okay with you?
Yes.
Okay. Make sure we sanitize our hands. Starting with the inspection, inspect the posterior chest area of any scarlet formation and abnormal lung interaction. Can you take a deep breath? Now moving on to the palpation, palpate any areas of the patient and ask the patient if they feel any tender in the areas. Do you feel any pain?
No.
In the test of chest expansion, make sure you keep both hands on the 10th and the coastal space and ask the patient to take a deep breath. And also for the chest expansion, whether it is symmetrical or non-symmetrical. Now in intactile phreatitis, we use the ulnar side of the palm and ask the patient to take a deep breath, and it is mainly used in the interscapular space. Palpation technique. For this we have to use a flexor finger, not a finger pad, and place it on the posterior chest and tap it twice. Comparing the both sides of the chest, and then you have to repeat the same technique as we used in the earlier. Then now we will percure. While percuring, we have to move in a ladder pattern. For example, if we percure here, then second you have to percure here. We have to move in a ladder pattern. Next is diaphragmatic exclusion. For this we have to note the dullness and the resonance area of the lung. This will be the resonance area. This is the dullness, and this is diaphragm. If there is diaphragmatic exclusion, you will feel dullness more above the normal level. Next is auscultation. For auscultation, we have to use a diaphragm or the stethoscope, not the bell, and we have to auscultate in a ladder pattern and ask the patient to take a deep breath. Can you take a deep breath, please? There are 4 sounds we should be listening. First is vesicular, which is listened to all over the lungs. Can you take a deep breath? Bronchiovascular, which is heard on the first and the second intercostal space. Can you take a deep breath? Bronchial, which is heard on the bronchus. Can you take a deep breath? And last one is tracheal. For any abnormal sound, make sure you listen to the transmitted sound. First one is whisper pectorally. Ask the patient to say 99 in a whisper form. 99. And for the bronchophory, ask the patient to say 99 louder.
99.
My name is Jefferson Ruskin. Now I'm going to do heart examination. Before doing the examination, I'm sanitizing my hands. What is your name?
My name is Jayhari.
Can I use you for my heart examination?
Yes, sir.
Place the patient in supine position and then turn neck to about 30 degree horizontally. Then illuminate the right side of the neck obliquely to the top level of the venous palpation. Place ruler 1 on the sternal angle and then place the ruler 2 at an exact right angle to the ruler 1. This constitutes the horizontal line. And now move the ruler up and down. Maintain the horizontal positions so that its lower edge rests at the top of the jugular distance. The vertical distance of ruler 1 is the regular venous pressure. Add 5 cm to the central venous position, and so you can get JVP. Carotid pulsations may be seen medial to and higher at the base level of the sternocleidoid muscles. You can use your thumb or index finger to palpate, and then you can use a diaphragm of the stethoscope to auscultate. Palpate the chest walls for any heels or thrills. Using your finger pads, palpate the second intercostal space along the border of the sternum. To check for thrills, palpate the same location with your ball of your hand. Thrills suggest underlying turbulent blood flow. It changes how you grade your heart numbers. Stand on the right side of your patient and flash a flashlight gently on the pericardium and locate the apex beat. Place the second and third finger on the visualized apex beat and then note its amplitude and rhythm. Palpate for the right ventricular impulse and the lower left sternal border. Place one finger in the third intercostal space and one in fourth and one in fifth, and then feel for the ventricular impulse. And then in the epigastric region. To identify first and second heartbeat sounds, place your diaphragm at the base and apex, and vice versa. As you listen to the heartbeat, gently palpate the carotid pulse. The upstroke corresponds to the S1, which is the beginning of the systole, and the other sound is S2. Start from the base over the aortic region and inch gradually to the pulmonic valve area, and downward to the tricuspid area, and then to the mitral valve area. If a murmur is heard over the mitral valve area, listen for the radiations by inching the stethoscope laterally and superiorly over the mid-axillary line. If a murmur is heard over the aortic area, listen for radiations over carotid arteries. Listen through the several respiratory cycles. To listen the extra heart sounds S3 and S4, ask the patient to lie in the left lateral decubitus position. Place the bell slightly over the apex and listen for possible heartbeats S3 and S4. Now ask the patient to sit up. This moves the left ventricular closer to the chest wall, and this helps to detect the murmurs of the aortic regurgitation.
Today I am gonna do abdominal examination with you. Is it okay with you, sir? Okay. I'm gonna ask you it first. If you have any pain, you have to tell me, sir. Okay? Okay, sir. Okay, all good. I'm gonna do precaution. If you have any pain, you have to tell me. Okay? Okay. If you have any issue. Okay. Next, I'm gonna do palpate. Do you have any pain, sir? No, sir. Could you lie neck? Yeah. Just like that. Okay, thank you. Your abdomen is flat and no tenderness, no pain, no masses. You good to go, sir. Thank you. Thank you.
Washing our hands is the first and important step when you examine your patient. I'm Manisha to perform liver and spleen examination. They both are lying in the right and left upper quadrants of the abdomen, checking for the symmetry, temperature for any kind of inflammation. Don't forget to examine the skin for any kind of lesion, scar or dilated capillaries.
First, put your left hand under the patient for support and start palpating gently with your right hand. try to reach the liver when the patient inhales. If you palpate the liver easily, then it may be large or inflamed. You can only touch the edge of the liver while palpating. In obese patient, hooking technique is used to palpate the liver.
Now I'm going to locate the liver by percussion. I start from below the level of umbilicus along the right mid-clavicular line, percussor upward toward the liver. I hear the dull sound and continue to percuss to find the upper border of the liver. And now I hear the different clear sound and located the liver. With your right palm, try to palpate the spleen. Be gentle. Keep your left hand back to the patient. To make it easy, turn the patient towards right and try until you reach. When the patient inspires, bring your two hands closer and palpate. Locate it clearly. Try to hear the dull sound in the left 8th to 10th intercostal space. Now I'm going to locate the spleen by percussion. I start by palpating the ribs for percussion. I hear the dull sound starting from 11th intercostal space. I continue to examine. I hear different clear sounds above the fourth rib. So I have located the spleen. From this liver and spleen examination, I didn't find any pathologic condition or abnormalities. So I state that the patient's liver and spleen are healthy.
Keeping the patient's health history in mind and following proper hand sanitization, we begin with the examination.
Hi there, I am Reshma, medical student. May I know your name and age, please?
David, 51 years.
Today I have been asked to examine your shoulder. Is that okay?
Okay.
It will just involve me looking your shoulders and examining both your shoulders. Have you got any pain at the moment?
No.
Okay, now take off your shirt. We will start the examination.
Inspect the counter of the shoulder and shoulder girdle, clavicle and scapulae and the surrounding musculature for any muscular atrophy, swelling or deformity.
I am going to start by feeling your temperature.
Range of motion: forward flexion, hyperextension, abduction, adduction, internal rotation, external rotation. So these are some special manuals of shoulder. First, crossover adduction test, apply scratch test, knee impingement, Hawkins impingement, drop arm test, empty can test, infraspinatus test.
My name is Manu and I am a second year medical student. May I know your name and age, please?
I'm Neela. My age is 47.
Okay. Today I'm going to be performing a wrist examination on you. Will that be okay? Yes. So before we begin the procedure, let's sanitize our hands. So to begin with, I'm going to be giving you a pillow and I want you to place your hands on this. The first step is inspection of the dorsal and palmar sides of the hands. Can you turn it like this? Check for any abnormalities, muscle dystrophies or tenderness. Okay, that's good. Next we move on to the palpation. Can you turn your palms like this? Firstly, I'll be palpating your wrist joint. So to begin with, I'll palpate your wrist by placing my thumbs on the dorsum of it and the fingers beneath it. Take note for any swelling, boginess or tenderness. Okay, that's good. Now I'll be palpating the metacarpophalangeal joints. While palpating, check for any swellings, tenderness or boginess.
Okay.
Next I'll be palpating the interphalangeal joints, which is the pips and note for any tenderness, swellings or boginess.
Okay, thank you.
Now I'll be inspecting the range of motion. So for that, I'll be performing certain wrist movements and I want you to repeat them after me. Will it be okay?
Okay.
Okay. For the first one is flexion of the wrist. Extension of the wrist. Now place your palm on the pillow and turn them outwards. This is called the ulnar deviation. Move with them inwards, the radial deviation. Now turn your palms like this. Make a fist. Release it. Now spread your fingers apart and bring it back. Now for the flexion of the thumb, I want you to bring the thumb to the tip of the little finger. For the extension of it, take it back to its position. For abduction of the thumb, take the thumb away from the palm as much as possible. Adduction of the thumb, bring it back. Next we move on to the special maneuvers of the wrist, the carpal tunnel syndrome. The first one is Tinel sign. Can you turn your palms like this? Tinel sign is checked by tapping on the course of median nerve in the carpal tunnel. Did you feel any pain?
No.
Okay. Next we are going to perform the Phelan sign test. I need you to place your wrist in flexion like this and keep your elbows extended. Observe the patient for about 60 seconds. Okay, you may release it. Did you feel any pain?
No.
Okay, thank you.
Hello, my name is Bharatwaj Dheeraj, a second year medical student. May I confirm your name and date of birth, please?
My name is Charan Singh sir, and I born in 2002, September 23rd.
Okay. I am going to perform a knee examination. Is that okay with you?
Yes sir, okay.
Ask the patient to lie in a supine position with his knees in flexion. Inspect the knees for their alignment and check the deformities. Note the loss of the normal hollows around the patella or an atrophy at the quadriceps muscle. Straighten the patient's leg and palpate the suprapatellar pouch on the each side of the quadriceps, noting any swellings. Now palpate the tibial femoral joint, the edge of the tibial plateau, and the margins of the joint. Note any irregular bony ridges. Now I am palpating the medial meniscus and the lateral meniscus. With the knee flexed 90 degrees, assess the medial joint compartment for any tenderness. Then palpate the medial femoral condyle, the adductor tubercle and the medial tibial plateau. Also palpate and identify the medial collateral ligament. Assess the lateral joint compartment and palpate the lateral femoral condyle, then the lateral tibial plateau and the lateral collateral ligament. Now we are checking for the range of motion of the knees. First, we're gonna look for the extension and flexion. This is done to be 2 to 3 times. Now we're gonna check for the internal rotation of the legs and the external rotation of the legs. Now we're gonna perform special maneuvers, which is McMurray test. Now we're gonna do the drawer sign test, where we draw the tibia forward or backward and observe if it slides like a drawer. Now we're gonna do the varus stress test. This test shows the lateral joint line gap. Now the valgus stress test. It is used to assess the integrity of medial collateral ligament of the knee.
Performing a good hand hygiene is very important before starting the physical examination. Good morning, my name is Ahmadi Mahek, and what is your name?
My name is
I am beginning with cranial nerve 1 olfactory nerve examination. Before starting the examination, I am making sure if each nasal passage is open. For this, I am occluding one of your nostril. Can you please sniff through the other? Now the opposite one. Please close your eyes now. I will be occluding one nostril. Can you smell anything? What is it?
Lemon.
Okay, the other side now. Can you smell anything? What is it?
Coffee.
Cranial nerve 2 optic nerve, which I'll be performing visual acuity test and using a Snellen eye chart. Can you please stand 20 feet away from this chart and close one of your eye using this index card? Now read the lowest line possible.
D, E, F, G, O, P, E, C.
You read from line 8, which means you have a vision of 20 by 20. Now we'll repeat the same thing with the opposite eye. Next, for visual field, I'll be performing static finger wiggle test. For this, I'm making sure the patient is at an arm's distance from me. You have to close your right eye. I'll close my left eye. You have to look straight into my open eye, okay? I'll wiggle my fingers and you have to say now as soon as you see the fingers, okay? Close your eye. Look straight.
No. No. No.
Moving on with the fundoscopic examination. For this, I'm using an ophthalmoscope. I'm making sure it is on, and I've moved the diopter to 0. I'm examining patient's right eye, so I'm holding it in my right hand, moving it 15-degree laterally, and I'm moving inwards. When examining the left eye, hold the ophthalmoscope in left hand. I paid special attention to optic disc and I looked for papilledema, pallor and on any cup enlargement. Testing for cranial nerve 2 and 3, optic and oculomotor. For this, I'll have to check patient's pupils, size and shape. I'll be using a pupil size chart. Look straight. His pupils are 3 mm unround, which is absolutely normal. Moving on with the light reaction. For this, I'll have to dim the room's light. I'm using a bright light and shining it obliquely in the patient's left eye. As you can see, the left pupil constricts. This is direct reaction. And as I put the light in the left eye, the right pupil also constricts. This is consensual reaction. Next is test for convergence. I'll be using a pencil. I'll move this pencil towards you, just focus on it. As you test for your reaction, again I'm using a pencil and placing it 10 cm away from the patient. You have to look alternatively at the pencil and in the background. Focus on the pencil, look in the background. His pupils are round, equal, symmetric and reactive to light and accommodation. Testing for cranial nerve 3, 4 and 6, oculomotor, trochlear and abducens. Just follow my finger as I move it in the shape of H. patient doesn't have any nystagmus or ptosis.
Hello, I'm Manikandan Jayashree. I'm going to examine the CN5 nerve. It has sensory and motor pathways. And first I'm going to examine the sensory pathway of CN5 nerve. So I'm going to use a cotton ball. Now I'm going to tell the patient to close your eyes. Close your eyes. Tell me if you feel anything.
Okay.
How do you feel?
Soft.
This?
Soft. 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 Soft.
Okay. Now I'm going to check for corneal reflex. Okay. For motor function, I'm going to ask the patient to bite down. I'm going to check for temporal and masseter muscle. I'm going to ask the patient to move the jaw against resistance. Okay. Now I'm going to examine the facial nerve CN7. For that I'm going to ask the patient to close their eyes tightly. Open. Okay. Now show your teeth. Smile. Without your face. Close your eyes. Open. It shows normal facial nerve reflexes. Now I am going to examine the vestibular nerve CN8. For that I am going to place my hand on the left ear. Tell the numbers.
Okay.
2, 8.
2, 8.
44.
44.
I am going to do the same thing on the right side. 68.
68.
47.
47.
Okay. Now I am going to examine the rhinitis, bone conduction and air conduction on the ear. So I am going to place the tuning fork on the mastoid process. Do you hear anything?
Yes.
Do you still hear anything?
Yes.
Okay. Now I am going to examine the Weber test. For that I am going to place the tuning fork on the head. Do you hear any sound on the lateral side or in the middle?
Middle.
Okay. For vestibular test, turn the head maximally. Yeah. Check for vestibular.
Firstly, you have to wash your hands. Hi, my name is Bharati. I'm a second year medical student. May I know your good name, please?
My name is Anita.
Okay, thank you. What's your age?
30.
Okay. Today I'm going to examine cranial nerves 9, 10, 11, 12. Are you okay with that?
Yes.
Firstly, I'm going to examine cranial nerves 9, 10, that is glossopharyngeal nerve and vagus nerve. Firstly, I sanitize my hands. Can you sip glass of water? Did you feel any difficulty while swallowing?
No.
Okay, there was no delay while swallowing and the patient don't feel any difficulty. And now you have to say ah with your mouth wide open. Stop. Ah. Now I'm going to check gag reflex by the tongue depressor into your mouth to the back of the tongue. Okay. So there is no deviation of the uvula and soft palate and pharynx are rising normally. In case of unilateral CN10, the uvula points towards the normal side. In case of the bilateral CN10, we can see the palate doesn't rise. Now I'm going to check gag reflex by the tongue depressor into your mouth to the back of the tongue. Okay. Now we are moving to the CN11 examination, that is spinal accessory nerve. I just standing behind the patient. I'm going to do inspecting. There is no atrophy and fasciculations around the neck. Now I want to strike your shoulders against my hand. Don't let me put your shoulders down. Okay.
So there is no weakness of the trapezius muscle and the strength is normal. Now move to the, now I am going to test sternocleidomastoid now. Now I am going to rotate your head against my hands. Okay. And the sternocleidomastoid muscle strength is normal. And now we are going to do test of the CN12, that is hypoglossum now. Can you open your mouth? Okay. So there is no atrophy and fasciculations on the tongue. Can you put your tongue outside? So the tongue is centrally protruded and symmetrically there is no deviation. Stop. Can you please move the tongue side by side? This. So there is no weakness of the tongue. So we reach the end of our examination. Have any questions and concerns? No. After the reinforced sleeping test, touch my index finger and nose alternatively even though I'm moving my finger. Okay. After the rapid alternating movement test, now you have to rapidly tap your knees with the front and back of your hand.
Okay, now we'll start with the heel to shin test. Place your heel at the shin of your other leg.
Can you walk across the floor normally several times? Have a stand up walking. Just go once from here to there. Now, can you open your toes to the Thank you. Now we start the heel. Now from the place from the head. Place your after the drop upstairs, please keep your close your eyes for 30 seconds.
For sensory testing, I want you to close your eyes at the time I ask so that I can check on the test I will be testing on you. So, for sensory testing, first test is superficial tactile sensation. In this, I will be placing this cotton bud on either sides of your face so that you should tell me on do you feel it or not. Okay? So, close your eyes.
Okay.
Do you feel it?
Okay.
Do you feel it?
Yes.
Do you feel it?
Yes.
Okay. Now the second test is superficial pain sensation. Here I will be placing this toothpick with a sharp and numb side. You should tell me which side I placed on your hand. Okay. Close your eyes.
Yes. Sharp, numb. Sharp, numb.
Okay. So the next test is sensitivity to vibration. Here I will place this tuning fork on some parts of your body, so you should tell me whether do you feel the vibration or not. Do you feel it?
Yes.
Do you feel it?
Yes.
Now?
Yes.
Okay. Now I'll be testing the position sense. In this, I will move your thumb toe up and down. You should tell me which movement I am performing. Here, this is up and this is down. So you should tell me now which movement I am performing. Okay.
Up.
down, up, down. Okay. So the next test is cortical or discriminatory forms of sensation. In this, the first test is 2-point discrimination test. Here, I will be placing this paper clip with two sides. I may be placed a one side or two sides on your hand. You should tell me, do you feel one side or two side? Okay. Okay. One side, two side, one side, two side. Yeah. The next test is point localization. I will be placing this toothpick on your sides of your hand, so you should tell me where I placed the stick. Okay? Close your eyes. Okay. So the next test is point localization. Here I will be writing something on your hand. It may be alphabet or a number. Then you should tell me what I wrote on your hand. Okay. Now 1. Okay. See? Yeah. So the last test is extension phenomena. Here I will be placing my both index fingers on your either hands. I maybe place one finger or both fingers simultaneously. You should tell me whether I placed one or both. Okay? Okay. Okay. Now 1, both, 1, both.
Today I am going to do motor testing of your lower extremities. First I start with inspection. I look for muscle work in your right as well as left legs, and also for any tenderness. Next I am going to check different movements in your legs. Is that okay with you? Yes. Lift your leg up. Hip flexion, down, hip extension, thigh abduction, bend your knee flexion, knee extension, dorsiflexion, plantar flexion. Okay. And do the same for next leg. Okay. Hip flexion, hip down, hip extension. Bend your knee flexion, knee extension, thigh abduction, plantar flexion, dorsiflexion. Okay. Next, we are going to check strength of your muscles. We'll start from the proximal end and end to the distal. Is that okay? Yeah. Please lift your arm up. Don't let me put it down. Okay, good. Relax. That is L2. Next, don't let me put it down. Okay, so that is your quadriceps, that is L3. Don't let me pull it up. Okay, so this is your hamstrings, that is L5. Now bring your knees closer. Okay, don't let me pull them out. This is abductor and adductor. Next, take your foot up and now down. This is S1. Foot in. And now, those are your perennial muscles. Now to the other leg, please lift it up, don't let me put it down, and that is your L2. Next for the knee, this is abductors and abductors. Okay. Lift your leg up, don't let me put it down. Okay, relax. This is your quadriceps. Next for the hamstrings. Okay, now pick your foot up and down, that is your S1. In and out, that is your perennial muscles.
Test shoulder strength. Have the patient each arm first to 90 degree and 180 degree. If he can do this, have maintain adduction against resistance. press down each arms, it required more strength to resist pressure distally. So if the patient is weak, press closer. Put your elbow, arms and downwards to the test upward. To test upper arm strength, have your elbow to 90 degree and push against your hand to test elbow extension. And patient is stronger, you may need to stabilize her shoulder. With one hand provide resistance. With the other test the strength of wrist extension and flexion. Test combined strength of hand muscle by assistant grip strength. Have the patient full two of your finger, then try the pull your finger. Now test intermuscle strength.